Hello, this is Chris Chaplot. I'm a doctor of acupuncture here at Healthy Ways Wellness Center in Brookfield, Connecticut. This presentation on the physiology of pain and how to intervene is the first of a 2 or 3-part series. Thank you for joining. First, I'd like to start by saying that I've always had a strange fascination with pain. I know that sounds strange, but from the perspective of an athlete, I've always been intrigued with the concept of pain and how it, as a variable, can make you or break you as an athlete, or for that can even be looked at in many aspects of life. When I went to get my first master's of science at Southern Connecticut State University, one of the things that I did, I went for human performance, exercise physiology. I did a pilot study on pain. And ever since then, I've been continuing to do research in pain. And that's one of the reasons why I became an acupuncturist, is to help treat people with pain, acute pain and chronic pain, sports pain, injuries, etc. I wanted to learn all about pain and how it's prevalent with an athlete. And of course, getting older, along with my friends, patients, and family, it becomes an ever increasing factor in our lives. There's a lot of misinformation out there, not just from the internet, but from the medical community as well. Okay, let's start. First, I want to start by mentioning my references. A good portion of this presentation came from Heartstone School. The Heartstone School is an online school, and it had a wonderful course that I took called Pain Pathways and Correlating Herbs. The teacher was a fantastic teacher, excellent speaker, very smart lady by the name of Tammy Sweet. I encourage you to check out her website and all the wonderful courses she has to offer there. Other people I'd like to thank and that I used as a reference is my current teacher, Lupo Pissarro, and my other teacher, Alana Soto. They are both teachers of herbal medicine, and Alana Soto is a practitioner. Lupo Pissarro owns the Twin Star School of Herbal Energetics, and I've been going there now for quite a few years. One of the other books that was referred to me by Tammy Sweet is, and I ended up getting it, is a wonderful book called A Nation in Pain. Okay. So what we will cover, we're going to cover 4 types of chronic pain, the pain pathway of the body from the site of injury to the brain, the intervention points along these different pathways, and the interventions to assist yourself or others with pain. Many of my patients come to Healthy Ways with both acute and chronic pain. The best way to assist them in their healing path is to have a deeper understanding of the mechanism of pain, the reasons for it physiologically, and ways of relieving it when necessary. Again, in this series, we will explore the pain pathway from its origin through the nervous system all the way up to the recognition in the brain. We will also discuss the different types of pain, as I mentioned: acute, chronic, nociceptive, inflammatory, dysfunctional, and neuropathic, their etiology and mechanisms. And finally, we will explore the findings in pain research and the different methods to interpret or intervene in the pain pathway, how these interventions work, and finally, their indications and contraindications. Okay, pain. Everyone is affected by pain in some time in their life. You or someone you love can suffer unnecessarily from the lack of understanding on how to intervene along the pain pathway. Something as seemingly simple as touch can lower the perception of pain. Being a doctor of acupuncture, my whole bag of tools are used to help manage acute and chronic pain. This presentation will also help you understand and even utilize some of these tools. All right. $50 billion of lost wages gets big corporations motivated to do research because they're losing so much money. So here's some statistics, some interesting information. 80 million sufferers from chronic disabling pain syndrome. There's 80 million people who suffer from chronic disabling pain syndrome. 31 million at one time suffer from low back pain, resulting in $50 billion a year in lost wages. Over $8 billion a year is spent on pain medication. Headaches are 40% of primary care visits. Clinical depression is four times more likely in chronic pain sufferers. 90% of chronic pain cases have no structural impairment that they can find that is causing the pain. There's no tissue damage. Very peculiar. This is an interesting definition. This is one of the best definitions that I found. It makes the most sense holistically to me. It's by Judy Foreman. And it encapsulates the meaning in just a few words. I like it because it mentions the biological, the physiological, and the sociological aspects. It encompasses the whole person. A psychosocial phenomena of an unpleasant sensory or emotional experience associated with actual or potential tissue damage or described in terms of such damage. Okay. So here's a graphic definition of pain. As you can see here. Okay. Some more interesting information. This is actually a little disturbing. Something I want to mention as a note to consider for this slide in respect to pain physiology that you should know first is there's these little nociceptors or nerve receptors that feel pain or sends the pain stimulus to the brain. It's what initially registers the pain and tells us to be alert and or there's an issue like damage, tissue damage. The brain is the organ of pain that feels it and registers this. Up until the 1980s, it wasn't believed that children feel pain at the same level as an adult. They thought that they actually feel less pain than an adult. Well, that is completely false. And because of this, in the 1980s, children were often under-medicated. You have to think of it this way. A child's fresh, young, little liver filters medication quicker than an adult. Therefore, children need to be given pain intervention more often. This really needs to be considered when treating children, of course. Something that also needs to be considered with children is the scale. So, for instance, think of a little pin stick on the heel to get blood. And usually the doctor or the nurse says, no worries, it's just a little stick. What needs to be realized is the size of the child's foot, that being stuck. And if you were to translate that up to an adult foot, that little puncture feels more like a lance or a slice to the child's foot. It's all about scale and the size of the body. What they have found and have studied is that skin to skin contact, touch from mom or dad, helps lessen the pain. It actually, or physiologically, is known that touch in and of itself will reduce the pain signal, not just through a mental and emotional mechanism. As you can see, these other pieces of information about children feeling pain. Week 7, embryologically, nociceptives are formed, so very early. Week 20, fetal brain is developed and can register pain. Week 35 to 37, fetus is able to differentiate pain and touch, so they cognitively know the difference between pain and touch. 2 to 6 years old, they, as I mentioned, clears drugs faster and more frequent. Those little livers are working well. Always use non-opiate interventions anyway. Sugar increases endorphins and dopamine. Skin contact, familiar sense, and as I mentioned, mom or dad's touch and voice also increases endorphins. Now let's talk about women and pain and the misconceptions. So women tend to be under-medicated as well. Women have adapted through evolution to be more sensitive and in tune for any signal of danger, including pain. Women need to be alert. Traditionally, they have been the primary care person for the vulnerable ones, such as children and the elderly. They would be responding to cues of danger because they're going to have to help the vulnerable. So it makes sense that they will be more sensitive and in tune to pain. Here, let me read these tidbits. More likely to get painful conditions and report greater pain levels. Women are more sensitive to other signals, as I mentioned, of danger, smell changes, visual cues. Makes sense that they would feel more pain. Systemically under-medicated, coronary bypass study showed that 30 men and 30 women were given, the women were given sedatives and the men were given pain medication. 79% of all research done is on male mice. Testosterone protects against pain. Estrogen, they're not so sure of. In a transsexual study from males that convert to females, 1/3 developed chronic pain, especially headaches. 1/3 of those males that converted to female developed chronic pain. Female to male, chronic pain decreased. Okay, so here's the different types of pain. There's acute pain, which is rapid after the stimulus is applied. It's superficial. It's not in deeper regions of the flesh or the tissues. It's sharp, pricking, and short-lasting. The nerve fibers that conduct this sensation are called medium A delta fibers. Then there's chronic pain. There's different types of chronic pain that we're going to go into in detail, which is slow, more insidious. It increases intensity over seconds and minutes. The skin level is much deeper. The pain is excruciating, burning, throbbing, and aching. C fibers is what registers chronic pain. So that would be like diseases of the nervous system. So, or I should say, sorry, chronic pain is then considered a disease of the nervous system, not just a symptom anymore. That's where pain lasts 3 to 6 months or longer. Then there's referred pain. I think I have a slide on that. The next slide, I'll bounce to that. When the pain you feel in one part of your body is actually caused by pain or injury in another part of your body. For example, an injured pancreas could be causing pain in your back, or a heart attack could be triggering pain in your jaw or down your arm. And then there's the phantom pain, pain that feels like it's coming from from a body's part that's no longer there. Doctors once believed this post-amputation phenomena was a psychological problem, but experts now recognize that these real sensations of pain originate in the spinal cord and in the brain physiologically. Here, this is an example of referred pain. Here, this is like when there's visceral pain or pain with one of your organs, it will refer to the dermatome or to the outside body, to the skin. So as you can see here, having a heart attack or having an ischemia of the heart, that referral pain can be felt in the arm, particularly the left arm, and down all the way down into the pinky, so the chest and the arm, and then on the backside you could see there just medial of the right scapula. Okay, some more definitions that I'd like to mention before I go into more detail. So pain threshold is enough stimulus to initiate the firing of nociceptors to perceive pain. It's the same for everyone. Pain tolerance is the duration of intensity of pain endured before acknowledging and seeking help. Varies according to culture, age, sex, and emotional state. Okay, the different types of pain, the different types of chronic pain that we're going to be going into. That's nociceptive, inflammatory, dysfunctional, and neuropathic chronic pain. Okay. Nociceptive pain is the instant and intense feeling of pain, like stepping on a tack. It's adaptive. You want to pull your foot away from whatever is causing the pain, and that means the pain is alerting us. The stimuli is a mechanical force, bone on bone, heat injury, cold injury, acute injury, and then it's increased with heat or cold. Okay, inflammatory pain can be adaptive or non-adaptive. And the stimuli is tissue damage and swelling. Okay, So here's the pain pathway. This is an excellent drawing. This is not my drawing. This is a drawing from Tammy Sweet. As I mentioned, she's the instructor of the online Heartstone School. And this is a representation of the pathway of pain. Nociceptive pain, I'm going to continue talking about, and inflammatory pain. So where it all starts, as I mentioned before, is a noxious stimulus. And in this case, someone is stepping on a tack, leaving a puncture. What happens immediately at this point is where the punctured or damaged cells release a bunch of chemicals called cytokines. These cytokines are things like potassium, prostaglandins, bradykinins, substance P, histamine, etc. Okay. The prostaglandins here are what causes both inflammation and pain. At this point, it binds to the nociceptor, or the receptor of the nerve cell, which starts the domino effect in signaling of pain. It basically sends an electrical current along a nerve, traveling up the leg's nerve pathway, moving from nerve cell to nerve cell. When it enters into the central nervous system, the spinal cord, and moves up to the brainstem. At this point, the person still has not registered the pain. But up here, at what's called the switchboard of the brain, or the thalamus, which is the anatomical name, is when the pain is registered, telling the person, I have pain. At this point, the person knows that it's coming from somewhere, but not precisely. And the person doesn't register how much or to what degree they just know that they have pain. Then at this point, it goes to the limbic system, which is the emotional brain, where the person registers emotion. Now, the person has a feeling representation about the pain, and that feeling was formed or hardwired by the age of 3. It's unique and individual experience. People can emotionally understand their particular pain in many different ways. One person might cry, and another one might be sad. Some people might get mad, and some people even laugh. Whatever your emotional response is, it's really happening. At that time of the emotional label in the limbic system of the brain, it also goes to the somatosensory cortex, or the reflexology map, or homunculus of the brain. Now all the connections are made, and the person understands exactly where it is, where it came from. In this case, ouch, my arch hurts. The last step is the pain signal goes to the frontal cortex. This is the area of reasoning. This is where reasoning happens. And here is where the person asks the question, what meaning does this have for me? What do I need to do? Okay, so other things that cause nociceptive pain are examples are things like muscle spasm or organ distension. Like when you wake up with a sore, tight neck, you didn't do anything. It's just that you slept wrong, causing a muscle spasm in your neck. Other causes of nociceptive pain, as I mentioned, is the distension of an organ, like after eating too much on Thanksgiving or at a party. Not that you damaged your stomach, it's just that it's distended so far that the pain signal was released to warn you, change your behavior, and tells you to stop eating. That's the adaptive definition. Another example is an overexpanding bladder. Heat and cold will also signal pain, and it will before you do any damage. Pain is the original survival tool or mechanism. The body creates pain so that you will change your behavior before it's too late and do damage. Where we see chronic nociceptive pain is with osteoarthritis, where we see bone on bone grinding, or with heart disease and angina. The heart cells are signaling damage from a lack of oxygen or something. This pain is considered adaptive since the organism of the person will behave differently in order to prevent pain and learn from their mistakes. Chronic inflammatory pain, here is where you are feeling the swelling of the surrounding tissues and the prostaglandin release. The swelling causes so much fluid that it will affect the surrounding nerve endings and signal pain. Chronic inflammatory pain is maladaptive. In the next slide, I'll talk more about adaptive and maladaptive pain. Okay, here with these types of chronic pain is where things start to get a little strange in the realm of pain. The stimulus of dysfunctional pain is an amplification of the pain signal within the central nervous system. Something is boosting the signal within the spinal cord or in the brain. The strange thing is that there is no damage. There's no tissue damage or inflammation. As you can see, it's maladaptive. There's no damage to the nervous system, or is there inflammation. It's seen in diseases such as fibromyalgia, irritable bowel syndrome, and certain types of headaches. The nervous system is what relays nociceptive impulses or danger signals to the brain and potentially causing a pain experience. In the instance of spraining an ankle, these signals are absolutely adaptive in causing a protective response to enable the stages of healing. The Oxford Dictionary of Sports Science and Medicine in 2007 defines maladaptive pain is an unhelpful pain that tends to be out of all proportion to actual tissue damage and which persists long after the tissues have healed, so that the pain becomes the problem rather than the tissues from where the pain came from. Physiologically, that's why something like ibuprofen or Advil doesn't work here. However, the placebo effect is very powerful here. And we'll get into it in more detail. But if you believe a sugar pill, not knowing that it's a sugar pill, or something as simple as a beautiful scene or a painting or even a unicorn, if it takes the pain away, then it truly modifies the pain. And now you know what works and what can help you manage your pain. The placebo effect is a real mechanism for pain relief. However, if what you're taking has damaging side effects, then there's a problem. And that's with pain medication. Not saying that it doesn't have its place, but if it's not used properly, like ibuprofen or Tylenol, it can actually cause damage. And I'll go into that in more details later. With neuropathic pain, there is actual damage to the nervous system itself, such as with herpes zoster, shingles, This virus actually damages the nerve endings and signals excruciating pain. Or, say, a herniated disc that damages the nerves in the spine and constantly signals pain. Dysfunctional and neuropathic are very tricky to treat, especially if you're trying to treat them like nociceptive or inflammatory pain. Okay, let's move to the next slide. Here's another wonderful diagram that Tammy Sweet drew and gave it to us in her notes, and I'm going to pass it along to you. So here is basically where the nerve impulse carries pain by the way of neurotransmitters. Again, here's where the nerve cells communicate. One neuron meets another neuron. An electrical impulse heads down or travels along the axon of the nerve cell to the end site where the neurotransmitters, as you see here, or chemical messenger molecules are released to continue the communication to the next nerve cell, and so on. If the message is pain, certain neurotransmitters are released and cross over to the other neuron to continue the message to the brain. One of the neurotransmitters that communicates pain is called glutamate. And the reason why it has a positive sign is because it's excitatory. It's an excitatory transmitter. Another one that is an excitatory neurotransmitter is called substance P, which is nicely stands for pain, P for pain. An intervention that blocks these will block pain. GABA is an inhibitory neurotransmitter, and if it's released, will stop pain. BDNF is also another excitatory transmitter. What BDNF stands for is brain-derived neurotrophic factor, which is also another neurotransmitter that communicates pain. What they find with people who have dysfunctional pain, for some reason, the body starts to make more of these receptors for the pain transmitter. And the receptor is on what receives the neurotransmitter, the GABA, the glutamate, the substance P. And that is called N-methyl deaspirate receptor, which is a glutamate receptor and an ion channel found in neurons. Basically meaning these people become even more sensitive to pain. And some other people will strangely produce more pain neurotransmitters. Either way, these people are more sensitive to pain, and it's easier to cause pain. Sometimes these people with dysfunctional pain will have the GABA inhibitory transmitter, which helps to reduce pain. This molecule, for another strange reason, unknown reason, will become excitatory and enhance or cause even more pain, making these people even more sensitive. These people are so sensitive that even the lightest touch will feel like a knife stab. This is what happens. This is a brain image, and it shows a healthy brain and then a brain that has been affected by chronic pain. Chronic pain can age the brain up to 20 years. Other ways to increase pain levels would be the anticipation of pain. The emotions of anger, sadness, and loneliness will increase pain levels. Now, ways to decrease pain levels is to feel good, right? Fall in love, have good relationships. Remember, the first place that the brain registers pain is in the emotional center. That's before it even knows where the pain is coming from and what to do with the pain. Therefore, emotion has a big part in perception and, in turn, management of pain. Depression and anxiety makes opioid medication less effective. What eventually begins to happen in this mindset of depression and anxiety, that some people with depression and anxiety, with chronic pain, they have what is called catastrophizing. And this is obviously a maladaptive cognition and emotional behavior that leads to focusing obsessively on pain. This way of thinking amplifies the nervous system's processing of pain, which in turn has even more of a physiological effect on the body. In this case, even another excitatory transmitter is released called interleukin 6, creating even more sensitivity. Studies show that women tend to catastrophize more than men. The brain becomes less plastic or less changeable. As we know, the nervous system overall becomes sensitized. Well, that is the conclusion of my presentation. I want to thank you for listening. Again, I'd like to thank Tammy Sweet from the Heartstone Online School for all this information. I encourage you to check out her school. She's an amazing teacher who offers all kinds of related and interesting courses. The next class that I plan on taking at Heartstone is on inflammation. Thank you again, and stay tuned for part 2 of this series.